Good afternoon, everyone. Thank you for being here. My name is Nadia Primc. I am an associate professor for medical ethics at the Heidelberg University and one of the partners in the Erasmus project METIS. Our project brings together universities and partners from Luxembourg, Italy, Norway, Greece, and Germany. And this is the first of 3 lectures in this series on the ethics of artificial intelligence and digitalization in healthcare. The goal of today's lecture is to give you a general picture of the opportunities and ethical challenges that AI and digitalization bring to medicine and healthcare. And in my lectures to follow, I will then go deeper into more specific ethical aspects. Today, I will start with a clinical case and 3 scenarios. I will then, in the second part, introduce the basic ethical principles of medical ethics and show how they apply to these scenarios. And in the third part, I will very briefly use the example of AI in organ transplantation to make a broader point about the limits of general AI ethics frameworks. And as I said, I want to start not with a definition or a list of principles, but with a case. Our clinical case is the following one. A 74-year-old man fell at home and suffered a severe traumatic brain injury. When the ambulance arrived at his home, he was unresponsive. He was admitted to the intensive care unit, the ICU, where he has ever been since. 10 days have passed since his admittance to the ICU. His Glasgow Coma Scale score, that is a sort of a standard clinical measure for consciousness, has been 4 throughout these 10 days in the ICU. So to give you a sense of what this score of 4 means, a fully conscious person scores 15 on the Glasgow Coma Scale. A score of 4 means deep coma, with almost no observable response to the world around him. What is also important is that his score has not improved at all during his 10 days stay in the ICU. The patient has a history of type 2 diabetes, chronic kidney disease, and high blood pressure. And the overall assessment of the medical team is rather clear. They believe the prognosis to be very poor. So they believe that it is very unlikely that this patient will recover in any meaningful way. So that it is very unlikely that he will again regain the ability to interact with and respond to the world around him. Hence, the doctors are preparing to speak to the family about this prognosis. So they need to discuss the options with the family, whether one should continue life-sustaining treatment, whether one should withdraw life-sustaining treatment, or whether there are other options to consider. And to now explore the specific challenges that AI brings to medicine, I want to imagine 3 different scenarios that the doctors might face. Scenario A. In this first scenario, the team uses established clinical scoring systems, specifically the Apache 2 score and the SOFA score. For those who do not know much about the Apache 2 or SOFA score, the Apache 2 score is, which is short for Acute Physiology and Chronic Health Evaluation. So that's what Apache stands for. And this is one of the most widely used severity scores in intensive care medicine. It was developed in the United States in the early 1980s and has been validated in large groups of ICU patients all over the world. It is not a new or a very glamorous tool, but it is very well understood by medicine and clinicians. And here's how it works. The clinician records 12 physiological measurements from the first 24 hours in the ICU. Things, for example, like temperature, blood pressure, heart rate, breathing rate, oxygen levels, but also potassium, creatinine, and also the Glasgow Coma Scale. And these measurements are combined with the patient's age and whether there have been any chronic organ problems before his admittance to the ICU. And to combine all these variables and measurements, the doctors use a fixed publicly available formula. And the result of this formula is a number that then corresponds to an estimated risk of dying in hospital. So for our patient, which is 74 years old, he has a Glasgow Coma Scale of 4, an elevated creatinine level from his kidney disease. The Apache 2 score gives an estimated in-hospital mortality of around 85%. Alongside this Apache 2 score, the team also calculates his SOFA score. SOFA is short for sequential organ failure assessment. That is a score that is calculated by the team on nearly a daily basis. The SOFA score measures how well 6 different organ systems are working normally, mainly lungs, blood, clotting, liver, heart, and circulation, nervous system, and kidneys. And this score is recalculated from routine measurements, and it helps you to track whether the patient is getting better, whether the patient is staying the same, or whether the patient is getting worse. So it is in addition to the Apache 2 score and allows you to track a bit more the evolution of the patient. And in our patient, the SOFA score has been consistently high and has not improved. So both scores basically tell the same story. What is important, the clinicians know both tools very well. They also know, of course, that no clinical score is perfectly accurate, but these scores are robust, they are extensively validated, and they are completely transparent. So the clinicians know every variable that goes into these scores, and they also know how much weight is given to each variable. And of course, also they know the formula. The formula is documented and publicly available. Everybody can look it up who wishes to. In the second scenario, the hospital has recently introduced a machine learning system for predicting mortality. This machine learning system has been developed by a biotechnology company together with clinical researchers, and it has already been approved for clinical use. That's why the hospital has been able to acquire it and to implement it in clinical practice. The system was trained on a large number of ICU patient records from hospitals all across Europe. It processes a very large number of variables at the same time. So vital signs, laboratory results, medication records, imaging findings, diagnostic codes, and also the patient's full electronic health record, at least as far as it is available, goes into the system and its prognosis. Before this machine learning system was introduced in our hospital, it was tested against the hospital's own historical data, and it showed very strong performance, hence the decision of the hospital to acquire the system. On the plus side for the clinicians, this system is integrated directly into the electronic health records, and it updates its output continuously as the new data comes in. So it gives you a continuous update on the prognosis for your patients. And after 10 days in the ICU, the system outputs a predicted 90-day mortality of 90%. This means among patients with similar clinical profile to this one, approximately 90 out of 100 patients are expected to have died within 90 days. 90 days, sorry. The doctors can explain what the number means, so that it means that 90 out of 100 patients are expected to have died within 90 days. What the doctors cannot explain to the family is how the system has reached this number. The system is the intellectual property of the company that built and sold it. Its architecture is not publicly available. The variables it uses, the weight it gives to each, and the reasoning behind any individual prediction are not accessible. Not accessible to the family, nor to the doctor, and also not to the hospital larger clinical team. So the doctor know that the system was trained on a large number of ICU data and validated internally. They know it works well, but that is all they know and all they can tell the family. The third scenario is one in which the hospital also uses the machine learning system, but this system includes a so-called explainability feature. This is a kind of a system that has been described, that is similar to the one described by Thorsten Meyer and colleagues in this study you see here at the slide on the bottom right. That is a study that was published in the Lancet Digital Health in 2020, if you want to look it up. So this is a system that, like the system in scenario B, is a deep learning model. It has also been trained on a large number of ICU admissions for multiple hospitals, and it has also been validated in research studies and against the hospital's own data. This model processes acute physiological data like vital signs, laboratory values, medications, alongside with the patient's full electronic health record, so a bit similar to the system in scenario B. An important difference to the classical scores from scenario A is that this model also updates its prediction every hour. So it is not just a snapshot, it gives you a continuous picture. What is also important is that its accuracy improves over the course of an ICU stay. So the longer the patient has been admitted, the more information the system, the model has absorbed, the more reliable its prediction becomes. So it's less reliable on the first state of the patient in the ICU, and the longer the patient is in the ICU, the more reliable the system becomes. And after 10 days, where our patient is now, the accuracy is known to be very good in general. And after those 10 days, this system outputs a predicted 90-day mortality of 90%, the same number as in scenario B. What is different is that, as I mentioned briefly at the beginning, this model also uses an explainability technique. So for this specific patient at this specific moment, the system identifies and tells the doctors which variables contributed most to the prediction. And in our case, the display in the electronic health record shows the doctors that the three factors driving the prediction most strongly for our patients are his Glasgow Coma Scale score on day 10, the creatinine trend over the past week, and his age. So let me put these three scenarios side by side so that we can better compare them. The classical scores, scenario A, are based on 12 to 17 variables. They are calculated using a fixed publicly available formula. They predict in-hospital mortality, and their accuracy, established through external validation studies, is good to very good. The clinicians can explain every variable and its influence on the prediction to the family, and the formula is transparent to everyone who wants to look it up. The opaque machine learning model from scenario B uses a great but unknown number of variables with unknown weights. It predicts a 90-day mortality and updates continuously. Its claimed accuracy is high, but it is just a claimed accuracy because its real-world accuracy in this hospital is not yet fully known because the system has only been recently introduced. The clinicians cannot explain the reasoning behind any individual prediction. For them, the model is a black box. And the explainable machine learning model from scenario C uses a documented set of variables, including long-term medical history. It updates every hour. It also predicts 90-day mortality. It has an externally validated good accuracy after those 10 days in the ICU where our patient is now. And the clinicians can see which variables drove the prediction for this specific patient. But the internal weighing of those variables and whether the model learned patterns are appropriate for this specific patient remain only partially visible to the clinicians, so they cannot be sure about it. And the question I would like to ask you is, being confronted with these three scenarios, if you were the physician, the doctor, preparing to go into that family meeting, which of these three tools would you feel most comfortable using as the basis of the conversation? Or the other way around, if you were a family member, a member of the family of that patient, being asked to make decisions on behalf of your father, husband, or brother, whoever this patient is to you, which of these three tools would you feel most comfortable with as the basis for that conversation? I will now enable a voting tool through which you can cast your vote. So you can either opt for a scenario A, B, or C, depending on which one you would prefer as part of the healthcare team or as part of the family. Here is the vote. So you can choose between scenario A, B, and C. I will wait till everyone has locked in their preference. Yeah. And here are the results. As you can see, most of you voted for scenario 3. No one voted for scenario A, and only a few voted for scenario B, so the second one with the opaque model. I expected that many of you would choose scenario A because the classical score is transparent, the formula is public, you can explain it variable by variable, you know where it came from, how it was validated, and what its limitations are. And because choosing the most transparent and best understood tool is a very sound ethical position. But most of you chose scenario C, whose model is not completely transparent, but at least to a certain extent explainable. So there's also a difference between transparency and explainability. In general, we have a preference for transparent models and predictions, especially when we have to make a very serious decision, such as the one presented in our clinical case. And I want to take that preference seriously, and I want to complicate it a little bit. We, of course, all know that human judgment is not perfect. It is not free from bias. And we know that the clinical decisions from clinicians that are informed by transparent scores like the APACHE-2 score or the SOFA scores may themselves be shaped by additional factors that are neither visible nor consistent and neither visible to the family and maybe also not so conscious to the physician, to the healthcare team itself. And in that context, I would like to point out a very interesting study. That's the study by Kobler-Richter and colleagues. You find it here again on the right bottom of my slide. They published a study in which they examined decisions to withdraw life-sustaining treatment in patients with severe traumatic brain injury, so patients like the one in our opening case. What they did, they used data from more than 30,000 patients that were documented in the National Trauma Database of the American College of Surgeons, data that was collected between 2017 and 2021. And they used that data to train a machine learning model to predict whether a patient would have life-sustaining treatment withdrawn during their hospital stay or not. And the model they trained performed very well. So they were satisfied by the performance of the model. But when they examined more closely which variables were driving the predictions, they found something striking. One of the most strongest and independent predictor of whether a patient had treatment withdrawn, so it was historical data they used, was the hospital's own historical withdrawal rate. So how often that particular institution, that particular clinic had made the same decision in similar cases in the past. So that was a very strong independent predictor. In other words, two patients with identical clinical profiles, so let's say identical APACHE-2 scores and identical SOFA trajectories, could receive different treatment decisions, simply depending on which hospital they happen to be treated in. So what their study showed, and the machine learning system they used revealed, was that the institution's culture, its habits, its informal norms around end-of-life decision-making were a very strong and independent predictor of the outcome, separate from anything in the clinical data. So I want to be precise about what this study does and does not show. It does not say that the individual clinicians are biased or that classical scores produce bad decisions. But what it shows is that human decision-making process into which classical scores feed are not as consistent and transparent as we might like to think or as we might wish them to be. They vary across institutions in ways that clinical data cannot explain. So, of course, we want our tools. So we want to have tools, the tools that we use to make clinical decisions to be accurate. That's something that we want, that we desire our tools to have, that we expect our tools to be accuracy and to be accurate. But another important value, as I already mentioned, is transparency. So knowing how the tool works. So the optimum would be we have a tool that works very well, that is very accurate, and a tool that is transparent. We know how the tool works, and we can explain that to the family, to our colleagues, and also to ourselves. But the study that I just described reveals an important limitation. Transparency about the tool we use to make clinical predictions is not the same as transparency about the decision. So a perfectly transparent scoring system feeds into a decision-making process that is itself shaped by factors we cannot see, that are not explicit. The questions we need to ask ourselves is not only can we see inside the tool, but also can we see inside the decision? And what would it mean to make the entire process of decision-making, of clinical decision-making, generally accountable? And that is a question, or rather a cluster of questions that medical ethics and also ethics of AI in healthcare forces us to confront. Because what AI does is not, it does not simply replace human judgment, but it shapes human judgment. It changes what clinicians see, what they pay attention to, what they communicate to the families and to the patients, and also ultimately it influences how they reach their decision. And understanding that and evaluating it ethically requires more than just a preference for transparency or accuracy or both. It really requires a framework to enable that accountability of clinical decision making into which AI tools may feed into which AI tools may be integrated. Before I go more deeply into that framework, let me briefly take a short step back. So I have now used a case from the ICU and a predictive model that is used in the ICU. But this case and the predictive model that I just presented, are just one example of a much broader digital transformation that is currently underway in healthcare. Artificial intelligence is a so-called general purpose technology. What this means is it is being introduced across the entire range of clinical practice in virtually every medical specialty, and it affects virtually every professional group involved in healthcare. So doctors, nurses, administrators, and all other healthcare professionals. And there are great hopes attached to this digital transformation of healthcare. One famous example for such a positive view of the potential of AI to transform healthcare comes from the physician Eric Topol, who argues in his book that you can see here on the right bottom of my slide, that AI can actually make healthcare more human again, by taking over routine tasks and giving clinicians more time for what matters, the relationship with the patient. But this very hopeful vision comes with an ethical question that runs through all these domains that you see here listed in an exemplary way on the left side of my slide. An AI tool in general processes large amounts of data that the clinician itself cannot fully process. It produces an output that the clinicians may not fully understand, and it shapes a decision that has significant consequences for the patients. And the big question is, the big ethical question is, how do we make that process more accountable or accountable at all? And this is the question that is not unique to the ICU. It can also not be answered in a one-size-fits-it-all manner, because different clinical contexts generate different ethical questions. So a prognostic tool in the ICU or a diagnostic algorithm in radiology, a resource allocation system in organ transplantation, they each raise distinct ethical concerns, even when they share a very similar underlying technical architecture. So to answer the question how to make those processes and implementation of AI accountable, we need a framework that adapts to these specific clinical contexts. And this context dependence is one reason why the general ethical frameworks developed for AI fit the field of healthcare and the different clinical contexts only partially. So there are a lot of frameworks that have been developed. I have put some example here on the slide. For example, the European Commission's ethics guidelines for trustworthy AI, the OECD AI principles, or more specific for healthcare, the World Health Organization's guidance on AI in health. They all set out requirements that are broadly agreed upon. So they call for transparency, explainability, for accountability, fairness and non-discrimination, privacy, data protection, safety and reliability, and human oversight. So these are the principles that you would most often encounter when you look into different frameworks for AI. And they are not wrong, but these principles are not specific to medicine and to different clinical contexts. So they were mainly developed by computer scientists, engineers, legal scholars, and policymakers, and they engage only superficially with clinical practice and with the field of medical ethics. The good news is that we already have a strong foundation when we look at medical ethics, because medical ethics is a well-developed field with its own foundational principles that are rooted very deeply in the clinical encounter between clinician and patient. And that provides a more specific and more powerful framework for evaluating AI in healthcare than generic AI ethics principle alone could do. And that framework is built around 4 principles. The framework was developed by the framework of 4 principles was developed by the American philosophers Tom Beecham and James Childress. It is also sometimes called the Georgetown mantra because both of them were at the Georgetown University. So they are very famous and influential books. Principles of Biomedical Ethics was first published in 1979 and is now the single most influential framework in clinical and research ethics worldwide. You may encounter it in very different contexts, in ethics committees, in clinical guidelines, and sometimes even in legal reasoning about healthcare. And those 4 principles are autonomy, so the respect for the patient's right to make decisions about their own care; beneficence, the duty to act in the patient's best interest; non-maleficence, the duty to avoid causing harm; and justice, which amongst other requires the fair distribution of benefits and burdens in healthcare. Each of these is a general moral obligation for healthcare professionals, and these principles do not always point in the same direction. They may conflict, and when they conflict, the task of medical ethics is to reason carefully about how to balance them. So what I would like to do now is to apply those 4 principles to our 3 scenarios to get us a better sense and estimation of them. Let's start with autonomy. So autonomy means the patient's right to make informed decisions about their own care, free from pressure or any undue influence. In our scenario, the patient cannot exercise his own autonomy. He is in deep coma. What the principle of autonomy requires in such a case is surrogate decision-making. The family is asked not to decide what they want for the patient, but they are asked to decide what the patient would have wanted for himself. Surrogate decision-making means speaking for someone who can no longer speak based on his known values and expressed wishes. So to do this, the family must receive clear information that they can generally engage with. If we apply this to scenario A, the clinician can explain the APACHE-2 score variable by variable. The family can ask whether the diabetes is included, whether the kidney disease is accounted for. The physician can answer each question the family poses directly. The family can engage with reasoning, can also push back on specific inputs and ask for a second opinion that will use the same transparent formula. So their decision rests on information they can, with support, understand, and information that they can also question. In scenario B, the physician presents a number, a 10% probability of surviving the next 90 days. The family asks where that number comes from, what the model looked like, whether the prognosis would be different without the diabetes, and so on and so on. And these are questions that the physician cannot answer. The model is proprietary. It is owned by the company that built it and that sold it to the clinic. The family is in the end asked to make one of the most hardest decisions of their lives on the basis of a number that no one in the room can explain. And not because it is necessarily wrong, the number, it may be a very accurate prediction, but simply because it is not accessible. So the requirements of informed surrogate with decision making are not easily met in this case. And in scenario C, at least partial transparency, or let it better call explainability, is available. The physician can show which variables drove the prediction the most, and the family can engage at that level. So, for example, the contribution of the diabetes is at least partially visible. This is already more than scenario B offers. Whether it is sufficient for a decision of this gravity is a question that especially the principle of autonomy presses us to take seriously. So what the principle of autonomy reveals when we apply it to our case is that, first of all, transparency is not simply present or absent. It comes in degrees. And it also shows that transparency is not only a value in itself, but that transparency serves very often other factors and values that are important in clinical situations. And what matters ethically is whether the degree of transparency available is sufficient for the specific decisions being made. So for a surrogate end-of-life decision, that standard in general is set to be very, very high. Let's move on to the next two principles, beneficence and non-maleficence. So beneficence is the duty to act in the patient's best interest. And this requires more than good intentions on the side of the clinicians. It requires competence. That means a genuine understanding of what the available tools can and cannot do. In our case, this includes the question of whether it is in the patient's best interest to continue life-sustaining treatment. And this question depends on an honest and informed assessment of the prognosis. Non-maleficence, primum non nocere, first do not harm, is the complementary principle to beneficence. It requires that any harm caused to be proportionate, necessary, and also justified by the expected benefit. The two principles are, in general, evaluated always together. So the clinical task is a weighing of the expected benefit against anticipated harm. And in scenario A, again, the physician uses tools that he or she fully understands. So he or she knows their variables, their formula, the history of validation, and also the limitations of these formula, including the fact that the PASH-2 score, for example, was developed in North American populations in the 1980s and may not transfer perfectly to all patients and to ICU contexts nowadays, to ICU care nowadays, because, of course, intensive care has evolved and has gotten better. He or she can make a professional judgment about whether the tool is appropriate for this patient, and he or she can also communicate its limitations honestly to the family. So her clinical competence is intact in that scenario. Whereas in scenario B, he or she is using a tool he or she cannot examine and fully understand. So she or he does not know which variable the tool uses or how they are weighted. A clinician who cannot assess whether a tool is performing as claimed is in a position where he or she cannot fully carry out his or her duty of beneficence. Using a tool that one does not understand puts clinicians in a position of clinical incompetence, not because of any failing on their part, but because of the structural opacity of the tool itself. In scenario see the situation improves, but it is not fully resolved. So the physician can see which variables contributed most to the prediction, but the clinician does not know in the same way as in scenario A whether the model's learned patterns are appropriate for this specific patient. So whether a 74-year-old patient with this combination of conditions falls within the range of the patient, falls within the range of patients this model can reliably assess. So explainability is a genuine improvement, but it is not the same as full understanding. The fourth principle, justice, concerns the fair distribution of benefits and burdens in healthcare. So at the level of the individual patient, it requires that care is not influenced by characteristics that are supposed to be ethically or clinically irrelevant, for example, race, gender, socioeconomic status. Although, of course, gender may have a clinical importance as we begin to learn from the newly emerging field of gender medicine, but not in all cases. At the level of the health care system, the principle of justice requires that limited resources are distributed on criteria that are defensible and consistent, as for example in the case of the allocation of donor organs. And at the level of society, the principle of justice requires that healthcare does not systematically disadvantage groups that are already marginalized. Justice is definitely the principle that most explicitly connects clinical medicine to the social and political world. It asks not only what it is good for this patient, but also whether the system within which the patient is being treated is in itself fair. So in our specific ICU case, justice is less central than the other three principles because our clinical scenario is not about distributing scarce resources across competing patients in the ICU, like we had it a question that came up during the pandemic, and the triage of ICU places. So our case is more about the patient, the family, and the decision. But I just want to briefly flag one important justice concern that AI-based systems bring to clinical medicine more broadly. And that is a concern that will be at the center of our third lecture. The point is that all AI systems have to learn from historical patient data. And that historical patient data was generated by a healthcare system that already reflects social inequalities. And a system that is trained on that data reproduces those inequalities automatically without anyone intending it. And the clearest and most famous demonstration of this is a study by Obermeier and colleagues. You find it on the right bottom of my slide, that was published in Science in 2019. And they found that a commercial algorithm in the US that was used to identify patients who needed additional care and to allocate them care, that algorithm systematically underestimated the healthcare needs of Black patients. So in other words, the algorithm was supposed to identify patients who need more healthcare resources, and the algorithm systematically disadvantaged Black patients by overestimating their health status. That is, by making them look healthier than they actually were. The reason behind this was simple. So the algorithm used healthcare costs in the past as a proxy for healthcare need. Because of structural inequality in the US healthcare system, where less money is generally spent on Black patients than on white patients with equivalent healthcare needs, the algorithm learned that Black patients were healthier than they actually were. And the result was that this system reinforced the very structural inequality it was supposed to actually help to address. As I said, we will return to these issues in more detail in lecture 3, which will be dedicated entirely to questions of justice, inequality, and AI in healthcare. Let me now bring this analysis together. Applying the 4 principles to the ICU case has revealed something important. So each principle generates a specific context-dependent requirement that cannot simply be read off from a generic requirement of transparency, fairness, accountability, and so on and so on. Because what transparency requires for autonomy, namely clear and accessible disclosure that enables genuine decision-making or genuine surrogate decision-making, is different from what transparency requires for beneficence. For example, sufficient understanding of a tool's basis and limitations to make a competent professional judgments on the side of the clinicians. And this is again different from what transparency requires for justice, which may require the ability to determine whether a model's training data encodes and amplifies structural inequalities or not. So the same word, transparency, means different things in each context, because the ethical obligation it is serving is different each time. And the major generic AI ethics frameworks, be it the EU ethics guidelines for trustworthy AI, the OECD AI principles, or even the WHO guidance on AI in healthcare, and they ask, is the tool transparent? Is the system fair? Is there a human in the loop, for example? And these are not wrong questions, but they are formulated at a level of generality that is independent of the different clinical contexts. So they do not ask transparent to whom, in what form, and for what purpose, fair by what standard, for example, social justice or just statistical parity, or, for example, human oversight in what role, just a passive monitor or an active moral agent capable of independent professional judgment. These are all different questions, and it shows that there is a gap between those generic frameworks and the ethical questions that arise when we apply AI to the clinical context, to different clinical contexts. And closing that gap is what the ethics of AI in healthcare is actually about. It can help to close that gap, at least partially. And to again briefly exemplify this gap, I want to draw on an example from my own research, namely the implementation of AI and prognostic models in the field of organ transplantation. So together with colleagues from different countries, disciplines, institutions, we are currently developing an ethical framework for AI in organ transplantation, because organ transplantation, like many other domains within medicine, is a domain where AI applications are growing rapidly. So from the identification of potential donors in intensive care units, through clinical decision support for listing decisions, to AI-assisted organ allocation, surgical planning, and monitoring after the transplant. And it is an important area, as organ transplantation is a domain where the stakes generally are very high. So decisions about organ transplantations are not always, but in many cases, decisions about who lives and who dies, or who gets the chance to live and who will not be given that chance. Okay, what you see here on this slide is simplified graphic depiction of the transplantation process. So the transplantation process moves through several distinct stages. Stage 1 is the decision to refer patients to a transplantation center. Stage 2 is where, for example, the potential recipients are evaluated and listing decisions are made. The stage 3 is, for example, a stage where potential donors need to be identified in the ICU. So potential post-mortem organ donors need to be identified in the ICU. Then comes stage 4, where a decision has to be made which organs go to which patients and which patients will be posteriorized, not get a certain organ offer. And then you have, of course, the surgical phase and the perioperative phase, the post-transplant care phase, and maybe a patient will need a retransplantation as a certain stage, which is here marked as stage 7, such that the whole process is initiated again. So what is striking, so that's a very simplified depiction of the transplantation process, but the point I want to make is striking from an ethical point of view is that the dominant ethical logic shifts across these stages. So at the stage of the referral and listing decisions, so from stage 1 to stage 3, when doctors and patients discuss whether transplantation is the right path, the ethical framework is patient-centered. So the primary obligations of organ transplantations, the healthcare systems, are to the patient, their autonomy, their informed consent, their well-being. So the question at focus is, what is the right decision for this specific individual patient? And when you arrive at stage 4, which is marked in blue here, at the stage of organ allocation, so this is the stage when a decision is made about who among all the waiting patients, so all the patients on the waiting list, receives the next available organ. Here, that ethical framework shifts entirely. This, in general, is no longer a patient-centered decision. It is a question of more general distributive justice. So every organ given to one patient is an organ unavailable to the next patient on the waiting list. And the primary obligation here is not just to any individual patient, but to the fairness of a system that distributes a scarce, non-replaceable resource across potentially hundreds of competing patients. So therefore it is called an allocation-centered ethical framework. And after that, at the surgical and post-operative stages, the ethical focus returns to the individual patient, to the patient-centered ethical frameworks. And it is now centered on professional responsibility, the quality of care delivered by the clinical team. So now consider two AI applications in transplantation medicine. You see them at the bottom. I have taken two exemplary publications on two different AI use cases in transplantation medicine. Both are predictive models that produce probability estimates from patient data. They are technically very similar, although not the same, but they raise different ethical questions because they sit at different points in the transplantation process. And I will begin with the I Choose Kidney system, which you see at the bottom left of my slide. I Choose Kidney is a decision aid that helps a patient with end-stage kidney disease compare their personal survival odds on dialysis versus transplantation. So the clinician generally enters patient sex, existing conditions, time on dialysis, and other information into the system. And the tool then generates a personalized 1- and 3-year mortality estimates for each treatment path. So dialysis and transplantation in language accessible to patients. So this tool sits at the listing stage. So the stage 2 of the transplantation process. So if ethical logic is patient-centered, what matters is that this specific patient that uses the system in this specific consultation can understand the output well enough to make a genuine, informed choice for him or herself. So transparency, for example, primarily serves autonomy in this use case. And the second AI tool that I want to briefly mention are machine learning models that are used to rank patients on the transplantation waiting list. So who decide who receives the next available organ. So here we are at stage 4, the organ allocation stage. And current research shows that such models in general outperform the classical scoring systems that we generally use in transplantation medicine in their relative predictive accuracy. But they are at the moment not widely implemented in national allocation schemes, partly also for ethical and legal reasons. As I said, these tools, although they may be very similar to the I Choose Kidney system, they sit at the allocation stage. So their ethical logic is distributive justice. Transparency here does not mean that an individual patient can understand and consent to the output. It means transparency in that case means that the weights assigned to, for example, urgency, survival benefit, waiting time, and all the other criteria that are used in the allocation decision are visible and defensible to society as a whole. An algorithm that is sufficiently transparent for informed consent, like the I Choose Kidney system, may be entirely insufficient for the accountability that the public allocation system, as the allocation system mentioned in my second example, demands. So here, the transparency of the I Choose Kidney system may not be enough, even when it's available. So, for example, an explainability tool can tell you why a particular patient received a particular score. For example, that this patient was ranked third on the waiting list because of their age, their waiting time, or their predicted survival benefit. And that could be regarded in some sense as partially transparent. But that is a very different question than asking, is the overall system fair? So is the way urgency is weighted against survival benefit the right balance in this case? So this is the deeper ethical challenge that AI in organ allocation poses, and that is one that the generic requirements of transparency and explainability designed with for the individual clinical encounters are not equipped to address. So my broader point is that two AI systems that look technically very similar can raise entirely different ethical questions, depending on where in the clinical process they are deployed and whose interests they are primarily serving. And let me close this lecture briefly by restating the central arguments that I tried to make. So we began with a patient in the ICU and a family preparing to make one of the hardest decisions a family can face. We saw that the ethical significance of that moment depends not just on which clinical tools were used to reach a prognosis, but on whether those tools enable genuine informed decision-making, whether the clinician can assess their validity and limitations, whether any harms they may produce are visible and attributable, and whether the patterns embedded in their training data are free from the structural inequality. We then showed that applying the 4 principles, autonomy, beneficence, non-maleficence, and justice, to these questions generates specific, contextually grounded requirements that generic AI frameworks that are formulated at a level of abstractions independent of clinical context cannot capture. And I use the example of AI in organ transplantation to show that even within a single clinical domain, the ethical requirements may shift substantially as the context changes. So from the patient-centered logic to the individual consultation of the individual consultation to the distributive justice logic of the allocation systems. And a framework adequate to this complexity must be built from the inside out, from the specific ethical obligations that apply at each stage of the clinical process, and not from generic principles applied uniformly from above.